Patient Education Lesson 5. An individual's developmental stage significantly influences his or her ability to learn. This lesson will examine the developmental stages of learning and the effective learning strategies for each stage. We will also discuss the role of family in the patient education process. A deliberate attempt will be made to minimize reference to chronological age, as it is not the only predictor of learning ability. At any given age, there is a wide variation of abilities related to physical, cognitive, and psychosocial maturation and stress. Environmental conditions and available support systems also impact ability to learn. Examples include children with chronic illnesses that may be developmentally delayed or patients that regress developmentally when traumatized. There are 4 developmental stages of childhood. They are 1. Infancy and toddlerhood, 0 to 2 years old. 2. Early childhood, 3 to 5 years old. 3. Middle and late childhood, 6 to 11 years old. And 4. Adolescence, 12 to 19 years old. Characteristics of infancy and toddlerhood include rapid physical maturation and exploration of the environment and self, with children learning primarily through the senses. Therefore, this stage is labeled the sensoromotor stage. Erikson, the noted expert on psychosocial development, described this time as one where trust versus mistrust, and autonomy versus shame, and doubt emerges as a central issue. Language skills develop rapidly in this stage, and ability to follow simple step-by-step commands emerges, as does increasing independence. However, difficulty making up their minds, aggravation at personal and external limits, easy distractibility, and egocentricity are hallmarks. Teaching strategies should focus on normal development, safety, health promotion, and disease prevention, and be directed towards the parents or caregivers. Toddlers, however, may be capable of some degree of understanding. When children are ill, focus should be on easing the patient's and child's anxiety before teaching can begin. For short-term learning, read simple stories with lots of pictures, use dolls or puppets to act out feelings, use music or cartoon characters to educate, or perform procedures on a teddy bear or doll first. For long-term learning, focus on rituals, imitation, and repetition, and reinforcement learning through practice. Use games and encourage parents to act as role models. Early childhood is named the pre-operational stage by Paget and is marked by increasing independence and interactions with others. Thinking in this stage is literal and concrete. They want to know why, but are less concerned with how. Erikson marked this stage as one where initiative versus guilt, and children have an excess of energy and a desire to dominate, often leading to frustration and anger. Magical thinking is also part of this stage. Increased imagination can lead to many fears, including separation anxiety, disapproval, pain, punishment, and aggression from others, and a limited sense of time may make waiting intolerable. Teaching strategies include health promotion and disease and accident prevention. For the ill or disabled child, the caregivers are the best to engage to determine favorite games and toys that may be utilized in this learning process. Children's fear of pain and bodily harm may need to be addressed, allowing them to express fears openly and providing reassurance. Use less threatening medical terms such as fix, sew, or cover the hole instead of cut or knife. To encourage short-term learning, provide physical and visual stimuli, keep teaching sessions shorter than 15 minutes, relate information to activities or experiences familiar to the child, give rewards and praise, and allow the child to touch the equipment for hands-on learning. Long-term learning can be encouraged by having parents act as role models and reinforcing positive health behaviors and new skills. Middle to late childhood, according to Paget, is the concrete operation stage. This is the beginning of the syllogistic reasoning, which is the concept that a logical conclusion may be drawn between two premises. Conservation and causal thinking are other concepts that are mastered in this stage. Erikson described this battle between industry versus inferiority in this stage as children gain more responsibility and reliability, are influenced by forces outside the family, particularly peers. School-age children fear failure and being left out of social groups, and illness and disability. Specific conditions that may come into focus in this age group are behavioral disorders, learning disorders, obesity, diabetes, and asthma. Teaching should be focused on preparing children for procedures and interventions well in advance, encouraging active participation in managing conditions, providing nurturing and support, and helping children acquire skills to manage and carry out treatment regimens. Adolescence is marked by the ability to think abstractly and is known as the formal operations stage. Erikson described the stage as marked by the struggle between identity versus role confusion. Autonomy, independence, personal space, control, privacy, and confidentiality are very important and should be respected. Other important factors in this group are personal fables, which leads adolescents to believe they are invulnerable, an imaginary audience, where they feel that everyone is focusing on the same things they are focusing on. Since this is the most at-risk population for accidents and high risk for homicide, suicide, drug alcohol abuse, sexually transmitted diseases, and pregnancy, trust and respect must be ensured before an educational process can begin. Education may be done in groups as peers may help each other deal with issues, instructional tools and technology may be used, and respect, tact, honesty, and flexibility are important to elicit attention and encourage involvement. Allow them to test their convictions and acknowledge their feelings. Adulthood is also marked by stages from early adulthood, 20 to 40 years, middle adulthood, 41 to 64 years, to older adulthood, 65 years and older. Andragogy is the art and science of helping adults learn and is more learner-centered than teacher-centered. It acknowledges that adults move from dependent to independent personality, accumulate experiences, and have learning needs based on life situations and for improved quality of life. In young adults, Erikson focused on the struggle for intimacy versus isolation in this age group. Intimate relation decisions, lifestyle and occupation decisions, and managing home and family are important in this stage. Cognition and physical development are at full capacity, but the many required decisions can create high levels of stress. Teaching should promote healthy lifestyles and when treating illness or disability, focus on encouraging as much independence and normal life patterns as possible. Self-directed learning, focusing on problem solving, and immediate application is the most effective. Middle-aged adults generally are accomplished in their careers, their children are grown, and they have time to share their talents and mentor others. Erikson described this stage as generativity versus self-absorption and stagnation. The ability to learn remains steady in this stage, but physically changes such as slowing metabolism, lessening endurance and energy levels, and hearing and visual acuity changes can impede learning and motivation. Teaching strategies center around maintaining independence, stress management, and managing chronic illnesses. The older adult will constitute approximately 20% of the population in the next 30 years and may be suffering from at least one chronic condition. Patient education needs in this group are generally greater and more complex than in any other developmental stage. They are often dealing with the concepts of hope and faith versus despair. Geragogy, the teaching of older persons, must accommodate the normal physical, cognitive, and psychosocial changes. This group is coping with the reality of aging, mortality, and reconciliation of past failures and changes in lifestyle, and social status and changes with cognitive abilities. Teaching strategies should include concrete examples relating to past experiences, be slower in pace with repetition and brief explanations. Speaking slowly and clearly in lower-pitched tones may help those with hearing acuity loss, and minimizing the distractions and using large, well-spaced letters may help with vision acuity loss. Also make time, if possible, for the older patient to reminisce in a safe environment. Family is very important to patient outcomes as they can provide critical emotional, physical, and social support. Joint Commission standards include patient and family education, although it is best to identify a primary caregiver to receive this information. Readiness to learn is subject-oriented in children, but problem-oriented in adults. Therefore, there are often large differences in rates and capacities of learning throughout the life cycle. Teaching should be individualized according to the needs of the patients and their families, and the clinician, as the main source of health education, must determine what needs to be taught, when to teach, how to teach, and who to focus on when teaching according to developmental stage.